One of the clinical problems that we're facing when it comes to CAR T-cell therapy is fever in these patients. So a significant proportion, almost all patients, develop fever early on after their CAR T-cell transfusion, and it's always the question, is this fever that we're seeing associated to the cytokine release syndrome that is CAR T-cell driven, or is this associated with some kind of infection? Because CAR T-cell patients are usually heavily pre-treated, particularly in the relapsed refractory setting. They also do have a significant risk of infection, and treatment for infection apparently is completely different to the treatment of cytokine release syndrome. And so for the one treatment you use antibiotics, and for the other you use things like tocilizumab. And looking at a cohort of a total of 60 patients, we try to understand if we can do something like a prediction of a patient for a patient if a fever event in these patients is associated with CRS, or is it or if it's associated with infection. And we checked for different routine serum markers, inflammatory markers, namely CRP, interleukin 6 and procalcitonin and PCT, and looked if one of these factors might allow a prediction if this is an infectious event that we're looking at, or if this is a CRS related event. And we found that PCT, so procalcitonin, is the marker that is best suited to differentiate between CRS and infection. And when looking at the cohort, the total cohort of patients, we additionally looked on ways to improve the accuracy of that prediction. And what we did there was that we used the baseline CAR-HEMATOTOX score. This is a score that has been developed by our group, by CAR-HEMATOTOX, and has been published. So this is a score that incorporates information about the baseline hematopoietic reserve of the patient, so ANC levels and thrombocytes, and also incorporates information about the baseline inflammatory state of the patient, namely ferritin, and calculates from these different informations, these values that we get for the patient prior to lymphodepletion, a score, and this score ranges between 0 and 7, and then gives us a risk stratifier for hematologic toxicities after CAR T-cell therapy. And in our, when looking at the question about infection versus CRS, we combined this baseline HEMATOTOX score together with elevated levels of the PCT, so above a threshold of 1.5. And when these, when we combine this information, we can improve the prognostication for CRS versus infection, and we think that this might be a suitable marker to be used in clinics to evaluate that risk and make decisions on treatment of fever events accordingly.